Hey guys, welcome back to my channel, The ENT Resident. Today we'll be discussing about pleomorphic adenoma, which is the most common benign salivary gland tumor. In my previous class, I have discussed about the different benign salivary gland tumors and how do you approach such a case. Today we'll be going into depth about pleomorphic adenoma. You can also now purchase my notes. I have added links in the description. Okay, so let's get started with pleomorphic adenoma. What is this? So as I have said, this is the most common benign salivary gland tumor. It is a benign neoplasm of the salivary gland which consists of both epithelial and mesenchymal components. Because of them having both epithelial and mesenchymal components, they are sometimes known as biphasic tumor, also sometimes known as a mixed tumor. Now, what are these epithelial components? Epithelial components are of two types. They involve the ductal cells and the myoepithelial cells. And mesenchymal components can be chondroid, myxoid, osseous, adipose. Amongst these, myxoid is the most common mesenchymal component, and osseous and adipose are much rarer. So, pleomorphic adenoma, the term pleomorphic comes from the fact as you have seen over here, all of this architectural complexity that we are seeing over here histologically. That is the reason this is, because of all the varied morphology we are seeing here, this is known as pleomorphic adenoma. That's the reason behind the name. Now, if you look at the name pleomorphic, it might sound like as if it has taken its origin from different germ layers, but that is actually not true. Pleomorphic adenoma actually arises from a single germ cell layer, which is the ectoderm. The most common age group involved over here is 4th to 6th decade, and another important MCQ is there is a female preponderance in case of pleomorphic adenoma. MCQ question right over here is, can you name a benign salivary gland tumor which has a male preponderance? The answer to that would be the Warthin's tumor. Other than Warthin's tumor, every other benign salivary gland tumor has a female preponderance over here. So that's all about the basics of pleomorphic adenoma. Now let's look into what is the histogenesis behind pleomorphic adenoma. There are certain theories which can explain this. So the first theory is Dardick's theory. Dardick's theory states that the pleomorphic adenoma arises from intercalated duct reserve cells. These cells are actually pluripotent epithelial progenitors. The base of this theory is that pleomorphic adenoma has a purely epithelial origin. There is no other separate origin to explain the mesenchymal components separately. So it says that these intercalated duct reserve cells, they differentiate into ductal and the myoepithelial cells. And then these myoepithelial cells, they undergo mesenchymal metaplasia. And then these myoepithelial cells are responsible for all the stromal diversity that I just spoke about. So myoepithelial cells can give rise to myxoid component in the stroma, which can be due to glycosaminosecretion, chondroid component, which is cartilage-like structures, osseous component, which is bone-like, and adipose component, which is fat-like. So all of these variations in morphology that we are seeing in the stroma is happening because of mesenchymal metaplasia occurring in the myoepithelial cells. These changes, all of these variety that we are seeing over here is the reason why the term pleomorphic has been used. So the key part over here is that the stromal elements that we are seeing, they are considered mesenchyme-like, derived from myoepithelial plasticity. It is not considered to be true mesenchymal tissue. So that is what Dardick's theory is, which states that the pleomorphic adenoma has a purely epithelial origin, and this epithelial origin leads to mesenchymal metaplasia, leading to the various mesenchymal-like components that you see. The second theory is Willis theory. Now this theory is very different from Dardick's theory. This theory suggests that the tumor not only arises from epithelial elements but also from mesenchymal elements. That is the reason the term mixed tumor is used over here. So basically what they are saying is that pleomorphic adenoma has a dual origin. So there's epithelial cells as well as mesenchymal cells, unlike in Dardick's theory, which was completely epithelial in origin. So in case of Willis theory, the stromal elements are considered to be true mesenchymal tissue. Whereas in Dardick's theory, we saw that the stromal elements were considered to be mesenchyme-like, but they were not considered to be true mesenchymal tissue. So these are two of the theories. Third is, we have seen some chromosome rearrangements in case of pleomorphic adenoma. This is another MCQ question over here. In chromosome 8q21, we see a PLAG1 oncogene activation, and in 12q13 to 15, we see a HMGA gene involvement. So these genetic alteration that we are seeing, these support the theory of a single stem cell origin, which is the first theory that we spoke about, Dardick's theory, the ductal reserve cell with myoepithelial differentiation potential. So that's all about the histogenesis of pleomorphic adenoma. Now let's look at which are the common gland that it involves. So the most common site of involvement in 85 cases of pleomorphic adenoma is the parotid gland. And amongst the parotid gland, the most common site here would be the superficial lobe of the parotid gland. And only 10% has been seen to be arising from the deep lobe of the gland. So our most common gland is parotid, and within parotid it is the superficial lobe. Other sites are submandibular gland in 8% cases and minor salivary glands in 7% cases. This image over here, this is a parotid pleomorphic adenoma that we can see in the angle of the jaw. Amongst minor salivary glands, the most common site to involve is the palatal glands. So that's all about the different sites involved. These are all important MCQ questions everywhere. Next, let's talk about the most important part of pleomorphic adenoma, that is histology of the pleomorphic adenoma. So first, let's talk about the gross features. So if you had to look at the gross tumor, it will be an irregular to ovoid mass with well-defined borders. When you see a cut surface, it may be fleshy, rubbery, or glistening with a homogeneous tan or white color. Major glands, they have a thin fibrous capsule, but sometimes the capsule can be incomplete. Minor salivary glands are unencapsulated. Sometimes you may see areas of hemorrhage and infarction, and sometimes tumor pseudopodia protrudes into the surrounding tissue. And this tumor pseudopodia, basically some projections of tumor going into the normal tissue. This would be the reason why there is actually a high chance of recurrence in case of pleomorphic adenoma, because sometimes these pseudopods can be left behind in the normal tissue and you may not suspect it, but 10 years later the patient comes to you with a recurrence. So that's about the gross macroscopical features. Now let's look at the microscopical features. Now, as I have mentioned already, we have here two types of components, which is why this is known as biphasic tumor. We have epithelial components and we have mesenchymal components. First, let's talk about the epithelial component. So epithelial cells, these are arranged in multiple patterns. They can either be duct-like, they can be in solid nest, sheath or cord of epithelial cells. They can be trabecular and alveolar arrangement. These cells, the ductal cells over here that we are talking about, they are usually cuboidal, columnar, squamous or oncocytic. So if you look at the image over here, this right over here, we can see these are the ductal cells lining the duct. Second epithelial component is the myoepithelial cells. Now the myoepithelial cells can have varying morphology. These myoepithelial cells, they can either be spindle shaped, they can also look like a plasma cell, which is why these are known as plasmacytoid cells. They can also be clear cells which are rich in glycogen. So if you see in the image over here, these are all the myoepithelial cells that we are seeing. Now, myoepithelial cells are the ones who is responsible for the different stromal components, stromal or mesenchymal components that we will see. So the stromal component, the characteristic mesenchymal-like stroma which is produced by the myoepithelial cells, they can be myxoid areas, which is the most common type of stroma that we see in pleomorphic adenoma. They can be chondroid areas, which looks like cartilage. They can be osseous areas. They can be adipose tissue in some cases. And the firmness of the tumor will depend on the nature and the amount of stromal component that we are seeing. And this stromal component is the reason why this gives a pleomorphic appearance. So if you see over here, this area is the chondromyxoid stroma that we are seeing. So these are all of these points that I have mentioned, these are very important to know for you from your exam perspective. Histology of pleomorphic adenoma is very important. And if you find any kind of calcification or bone formation in a histology of a salivary gland tumor or even a parapharyngeal mass, that is a dead giveaway for it to be known as a pleomorphic adenoma, because pleomorphic adenoma has all of these components. It is very unique to pleomorphic adenoma. So that's all about the histology. Now let's talk about the clinical features. How will the patient present to you with? As I've mentioned in my earlier class, the single important presentation is the swelling. So there will be a single painless. It is important to remember here, whenever there is pain, that will suggest malignant transformation in the patient. So in case of pleomorphic adenoma, this will be a painless swelling. So a single painless, smooth, firm, lobulated, mobile swelling just below and in front of the ear. You can see the image right over here, the location of the tumor. It is a very slow growing tumor and it can actually grow to a very large size. On examination, we see something which is known as the positive curtain sign. So what is the positive curtain sign? So the first image over here, this is reflecting the positive curtain sign. So we know from anatomy of parotid gland that there is a deep fascia over the parotid gland which gets attached to the zygomatic bone over here. Because of this attachment, this fascia kind of acts as a curtain. It does not allow the parotid swelling to move above the level of the zygomatic bone. So any swelling, if it is superficial to the deep fascia, they will be able to move above the zygomatic bone. But because the parotid lies below this and the parotid tumor will be lying below the deep fascia, it will not be able to go above this level. This is known as positive curtain sign. Next is, we'll also see sometimes that the ear lobule gets raised. The second image over here depicts that the ear lobule gets raised because of the parotid tube involvement of pleomorphic adenoma. So this is all the superficial lobe involvement. In case the deep lobe gets involved, in that case you will be seeing that the swelling is more commonly located in the lateral wall of the pharynx, the posterior pillar and over soft palate. Now let's look at the image on third image over here. We are seeing this huge swelling over here in the lateral wall of the oropharynx, and this is arising from the deep lobe. It is pushing the soft palate. It is coming from the lateral wall of the pharynx. So any deep lobe tumor, it actually passes through the Patty's stylomandibular tunnel and it pushes the tonsil, pharynx, soft palate without any visible swelling outside. These patients, particularly these patients, will come to you with the complaint of dysphagia. Secondly, other than these were the features of deep lobe involvement of the parotid gland. And other than that, the swelling, there will be no fixation to the skin or any underlying tissue. It will be a very mobile swelling, and facial nerve involvement is very rare. In case the palate has been involved, if there is a minor salivary gland tumor, palatal swelling can end up causing difficulty in mastication, talking and breathing. So that's about the clinical features of pleomorphic adenoma. Now, a very long-standing pleomorphic adenoma can sometimes undergo malignant transformation and turn into carcinoma. In that case, it is known as carcinoma ex pleomorphic adenoma. This is the term used over here. What are the chances of this happening? If the swelling has persisted for 10 years, the chances of malignant transformation is 1 to 5%. And how will we suspect it? What are the features we'll be looking out for? If there has been a recent increase in size, pain and nodularity, involvement of skin or ulceration over the skin, involvement of masseter, facial nerve, neck lymph nodes, and restriction of jaw movements. These are all the red flag signs that you should be looking for so as to find whether the pleomorphic adenoma has undergone a malignant transformation. Next, let's talk about how will we investigate the case. This is same as any other benign salivary gland tumor, where our first line of imaging would be an ultrasound of the swelling, and this will help us in differentiating whether it's solid or cystic, whether it is intraglandular or extraglandular, and ultrasound will also help in guiding for FNSC. The accuracy of FNSC increases with ultrasound. Second is CT and MRI, which is not done usually in all cases, but if the tumor is very large, of more than 3 centimeter of the tumor involves the deep lobe or the parapharyngeal space, or if there is any suspicion of malignancy, in these cases we'll perform a CT scan or MRI. In MRI, the lesion will turn out to be well circumscribed, homogeneous and T2 hyperintense. Next is looking at the cytology. We'll be using FNSC, which is gonna help you in differentiating between benign and malignant lesion. And lastly, core needle biopsy, which is not usually done, only done if the FNSC has been inconclusive. So that's about the investigations of pleomorphic adenoma. Last of all, let's come to treatment. So our only treatment of choice over here is surgery. It is important to remember that. Now we'll discuss in terms of the different salivary gland. If the parotid is involved, which is most of the times, first of all, earlier we used to do a simple enucleation. However, that is not done nowadays. Why? This is not done because of the high chances of recurrence, because of the thin capsule. I have explained in histology that there may be a capsule, but the capsule is usually very thin. And also we find that they have pseudopods going into the normal salivary gland tissue. So that is the reason why enucleation is not enough to prevent recurrence in case of pleomorphic adenoma. So this has become outdated now. So the next surgery is a superficial parotidectomy. In superficial parotidectomy, we are removing the tumor along with the superficial lobe, and we are identifying and preserving the facial nerve. This is done for tumors which is limited to just the superficial lobe. Third is total conservative parotidectomy. If we are seeing that tumor is involving the deep lobe or it is extending to involve both the lobes, in that case we remove both the lobes of the parotid while preserving the facial nerve, and that is known as total conservative parotidectomy. There's another surgery which has been gaining more popularity, which is a more conservative surgery, and this is extracapsular dissection. Here we basically excise the tumor outside of its capsule along with a very thin rim of normal tissue. But here we do not do any facial nerve dissection. We do not identify the facial nerve. But this has very limited cases where we can do this. We can only do this if the tumor is very small, about less than 3 to 4 centimeter, and it is mobile and it is a superficial benign tumor. The advantage of this is that the surgery is much shorter and less morbidity to the patient. However, the only disadvantage here is the recurrence risk can be slightly higher if in case the capsule ruptures during the time of surgery. And last option for parotid is if it is involved the parapharyngeal space, in that case it is excised via the cervicoparotid approach, or if it is even too big to go through the cervicoparotid approach or too anterior for this, in that case we perform a transmandibulotomy or the transpharyngeal approach. So that's all about parotid pleomorphic adenoma treatment. Next is submandibular gland. So if the submandibular gland has been involved, we completely excise the whole gland along with the tumor. And we have to be careful to preserve the lingual, hypoglossal and the marginal mandibular nerves. It is important to remember that we remove the whole gland. We do not leave behind any part of the gland. The same is for case of sublingual gland involvement. This, however, we go via the intraoral approach. And lastly is the minor salivary gland tumor of the pleomorphic adenoma. In that case, we do a wide local excision with a cuff of normal mucosa or periosteum. In case the palate is involved, we excise down to the periosteum and when we do a flap reconstruction. So that's all about the treatment of pleomorphic adenoma. Now I've mentioned before multiple times how recurrence is very common in case of pleomorphic adenoma. Now one of the reasons is because of pseudopods present which invade into the adjacent normal tissue. So the rates of recurrence is about 2 to 5% after a superficial parotidiectomy. And usually the recurrence occurs about a decade, about 10 years after the original surgery. Most cases of recurrence are multicentric, and the recurrent cases they also have an increased risk of malignancy, about 3 to 6%. Now what are the causes of recurrence? So if you are performing a superficial parotidiectomy, if there has been a rupture or spillage of tumor during the time of surgery. Second, if you have incompletely removed the tumor. So these are the two main causes of recurrence in case of pleomorphic adenoma. In cases of recurrence, the imaging of choice would be to perform an MRI. This helps you in characterizing the recurrence and as well as detect further any other foci present or not. In terms of treatment, we'll have to perform a total parotidiectomy with the facial nerve preservation, and we should also try to consider post-op radiotherapy because this may be effective in reducing further recurrence. In case the recurrence has occurred in a tumor of the submandibular gland, in that case we should treat it with a selective neck dissection of level 1, 2, 3. This will remove the soft tissue that will harbor the recurrent disease. So that's about recurrence. And lastly, pleomorphic adenomas have an excellent prognosis if it has been excised properly. If in case it has not been excised properly, there are high chances of recurrence, and we have just discussed that. So that's all about pleomorphic adenoma. If you have any further questions on this, please note them down in the comment section and I'll get back to you.